don't you just take a picture of me and let me just talk?
Get it started.
So you can introduce yourself.
Okay, I'm Laurie Hanson. I'm a professor in the Department of Community Health and Epidemiology at the University of Saskatchewan. The department is located in the College of Medicine. And I was born and raised in Saskatchewan, Canada.
Right. Well, could you please introduce us the historical context of the primary health care in Canada?
For sure. The best way to probably introduce healthcare, I think, is through a story and of a very fundamental person, and that in the whole history of the creation of Medicare in Canada, and that's through the history of Tommy Douglas. So Tommy Douglas was born and raised in the prairies in Saskatchewan, and he's credited as being the author of Medicare in Canada. So the story about Tommy Douglas is that when he was a young boy, he was hospitalized at the age of 10, and he had a kind of a bone infection that he'd suffered some years earlier. His knee was in need of several surgeries, and without the money to be able to pay for those surgeries, he faced amputation of his leg. So a surgeon that was working with him, a specialist, told Tommy's parents that before the infection spread to the rest of his body and so forth, he could have this amputation avoided if they let him do some operations. And he would do those operations for free if his students were allowed to attend the surgery. And so Tommy Douglas's parents agreed to this, and the surgeries actually saved his leg. And people say that planted the seed in his mind at a very early age that would serve as his inspiration for his dream of universally available healthcare. So many years later, Tommy Douglas was an MP in the federal government, and then became the first leader actually of the first ever democratic socialist government in North America, which was in my province of Saskatchewan. And that was he led the party, the CCF, which later became the NDP, which today is the official opposition in Canada, for first time ever. And he introduced, in his role in government in the 1960s, introduced a plan for a universal healthcare system. And in 1962, this was the first ever in North America that such a plan had been introduced. And he met with a lot of hard opposition. Immediately after the declaration that was passed in the Legislative Assembly in Saskatchewan, there was a doctor's strike. A very important doctor's strike, and the doctor said, no, we will never work under those conditions, we will never be paid by the state, we disagree with this, we won't go for it. But they lost, eventually. There was a negotiation that happened, and it was the beginning of what was very early, or very soon after that, declared the national Medicare plan in Canada. So it was not an easy battle. Those are important things to remember in terms of creation of Medicare and the way that it rolled out in Canada. It took a very strong leader with an incredibly good vision. Right? It took being able to fight against the resistance that was put up by physicians, and it took ultimately a political party with some vision for universal Medicare. So all of those things were really important. Many, many years later, when the system had been in place in Canada for a long time, actually, there was a National Healthcare Act that was passed. So that lays out the principles by which Canada has Medicare. So I'm not sure if you're interested in that.
No, I think we can skip on the next step.
Okay.
Through the constitution of the primary health care.
Okay. Well, in order to understand how primary health care gets its place, you still have to understand how the system works, because it's interpreted differently in different parts of the system. So the Healthcare Act is a national act, but in Canada we don't have one healthcare system. We have a system that is actually governed provincially. So there are different systems for every province. All of them have to obey the 5 principles of the Healthcare Act. So they all have to maintain the universality, for example.
Which actually are?
The 5 principles are public administration. So there's a single payer. Nobody in Canada buys their health service, and then submits to a private insurer, as they do in the States. I'm not sure about Italy, what you do here, but rather there's one single payer system, and so public administration is fundamental to making it affordable to be able to have a universal system. So public administration is the first one. Comprehensiveness is the next one, and that means that all necessary services will be provided. Necessary services is interpreted differently by different provinces, but is similar in most of them. Universality, so that all persons are entitled to equal care. Accessibility, so that principle basically means that all persons should have reasonable access to medically necessary care, and including physician services, and they should not they should not have any kind of financial or other kinds of barriers. And the last one is portability. And portability is important because portability means that even though there's 10 different healthcare sort of services that are offered provincially or systems, if you are anywhere in Canada, you're always covered. So just with your provincial card, you can carry it anywhere and always have the right to healthcare. So those are the 5 principles. And then, as I said, it's organized provincially. So each province has some leeway in terms of how they can interpret what this means. And it's really, primary healthcare may not have been what began. I think the system began as sort of a hospitalization plan versus a primary healthcare plan. But as people noticed all over the world, everywhere, that hospital care is expensive, very expensive, and that most health is not created by the provision of hospital care. As that sort of recognition comes about, and particularly in early 70s and into that, then there starts to be a sort of a reorganization of services, and much more emphasis put right across Canada on primary health care. And primary health care then is influenced by a number of things that happen over the course of from the 1970s on in terms of how it rolls out. So there's some important kind of documents and conferences and so forth that were laid out. Those that are kind of internationally recognized are probably a couple. One was the Lalonde report, which really placed a lot of emphasis. It was a national strategy and that placed a lot of emphasis on health promotion. But the one that's known about and that was adopted by the World Health Organization that you might have heard of is the Ottawa Charter on Health Promotion. Right? And that document, it sort of segues with primary healthcare in terms of influencing how it was to roll out and the emphasis put on prevention and promotion of health as opposed to just hospital services. So there's a series of different things that have happened along the course of the creation of primary care services and influential reports that have moved. But the primary motivation really for moving more of our Medicare system into an emphasis on primary care services is really financial. Hospitals are expensive and they don't do much for health. They do things for sick people, but they don't do much for health. So that's sort of how we got to the place of primary health care.
Yeah, and how is the situation today?
Well, there is still a real emphasis on primary health care, but again, it's interpreted differently in different provinces, and sort of is not necessarily the primary health care that we think of when we think of Alma Ata, although there are examples of that. It's more what's often considered primary care, and primary care being that which is offered by family physicians. And family physicians are often, have been at least in the past, termed the gatekeepers. So your first point of entry into the health system in Canada is through primary care, which is primarily offered at least in the past, by family physicians. That's starting to become, in the last, I'm not going to put a time on it, but it's starting to become more multidisciplinary. So nurse practitioners might be your first point of care, or midwife or something else. But the primary care versus primary health care is a tricky distinction, I think, still in Canada. And primary care meaning it's the first point of entry into the health system. Primary health care is something that systems are still working out, but the emphasis that's really been emphasized in the last 10 to 15 years, I'd say maybe, really has to do with increasing emphasis on community primary care centers, for example, and they provide services around the clock. They create teams, so multidisciplinary care is part of the primary care. It's not a doctor-led system or a doctor-only system. There's more emphasis put on all kinds of programs to promote health. You wouldn't find a regional health authority anywhere in Canada that didn't have a primary healthcare team that organized all kinds of programs and services and so forth that were aimed at health promotion and disease prevention activities. Those exist everywhere, and it's an important part of the system. It still does not have, because it's actually cheaper. I mean, you can do a lot more with primary healthcare teams of people putting out programs than you can with hospital care. But they don't receive, still there's a struggle because hospitals and tertiary care absorb so much more money in the system that it often sort of acts as a bit of a deterrent to how much primary health care of those kind of services, especially community services, that you can offer. So we have primary care, we have primary health care, and the primary health care teams then, with their programs and services, are increasingly community-based and connected with community. So that's more like the concept of primary health care that we see in Alma-Ata, for example. They also do, management of chronic diseases. There's lots and lots of programs that are offered by the health system for diabetes patients, and those are all out. That's not care that's through a hospital. It's all care that's through community health centers. And community health centers actually are probably the best example of how primary health care can work. So. Community health center, I'm not sure if there's an equivalent sort of here, but community health centers in Canada, there's probably, how many are there? There's hundreds across the country. And they're the best example of the Canadian interpretation of Alma-Ata, in that they're people-centered primary health care. They're team-led. Many of them are cooperatives, so you're actually a member of the community health center. You have a membership which allows you to have a say in what services are going on and how services are run. At least in theory, there's a board of directors that's elected by its members, so patients themselves, and they're interdisciplinary. It's kind of a one-stop. They do lots of outreach. They do lots of health advocacy, and there's a whole system of community health centers that are sort of located right across the country, and those are a prime example of how primary health care is and ought to work.
Right, and about the community participation, could you tell us, please, actually how it works?
Well, there's a lot of different examples of how people have, I think, across the provinces. I know my own province best, of course, Saskatchewan,
sure.
And there's been a really interesting kind of by trial and error ways that communities have participated in. So when regionalization was going on some years back, where provinces devolved authority for healthcare services to a regionalized system. So there were originally a couple of dozen healthcare, they were at that point called regions or districts, and now they're called authorities. Those entities in the beginning, in order to set them up, the province had the idea that you could get community participation increased by actually having an elected board. So there were, on top of sort of provincial elections and municipal elections, there were actually elections for the health board. And people put forward nominees for that, and there were elected members. It became a bit of, I think, administrative nightmare, and they went away from massive elections in that way to more, shall I say, representative, but not voted representative bodies that ran the health authorities. So that was just an experiment. It lasted for a few years, and they decided against it because there was also a really low turnout in those elections. I think people were a bit unsure of what it was they were voting for. And so they went to another sort of system where there's lots and lots of opportunities for patients to give feedback throughout the system. So that's one way that they gather, that they have constant input. But more important, in the primary care divisions within each health authority, many of those programs, those that I was mentioning, programs for health promotion, health and disease prevention programs, are run in conjunction with community-based organizations. So they're completely outside of the health system itself. So there's maybe an anti-poverty coalition that works with the street health team that's part of the primary care team to ensure that there are harm reduction services offered in appropriate places. That's an example. And so community-based organizations work kind of in partnership with many of the primary care team programs to better and to worse degrees. There's some good examples and some not so good examples, but that's one way that they've, especially in primary care teams, primary health care teams, have increased the possibilities for sort of civic participation.
Right, I think it's enough.
Great.
Thanks.